All right, walk number 3,475,000. No. All right, number 10. I won't have any wind today. I hope you guys, maybe a few of you looked at my last couple of videos I dropped. One of them was on the shoulder and really focused mainly on the rotator cuff, and one specifically the supraspinatus. I didn't talk about the other three muscles. They don't tear as much. I mean, sometimes you do have a combination of the supraspinatus and infraspinatus, but you know, teres minor and subscapularis. Those are the main rotator cuff, rotate external and internal. But anyways, so yeah, so that was, and then I left a couple of nice little tags on some range of motion, some strengthening of the rotator cuff, as well as what I specifically worked on in that particular video, which was working on scapular stabilization when you're on your stomach, or what we call prone position. And hopefully you guys like that. Let's see. And then my last video I dropped just a couple of days ago, that one wasn't too bad. Hopefully you guys like that. And that one specifically, out of shape. Hey, so on that one specifically, we were focusing on several things. So if you guys have any questions about that, you can always DM me. Ask me during my live right now if you'd like to. The back and the hip seem to do well a lot in the next, but I'm going to do more this versus that types of diagnoses and treatment and stuff like that. People seem to like that, some compare and contrast type videos. So hopefully you guys look out for those. I think in my next one I'm going to focus on specifically, I'm probably going to go, as I call back, hey, hi Ernie and David, how you doing? Thank you, Ernie, for throwing a shout out at me a couple Sundays ago. That was very nice of you. It's funny, only I think 3 years I've been doing this. You can see how my face has aged a little bit in just 3 years, so I can only imagine what the next 3 years will do. Of course, David, I got a question for you too. So on my videos that I do, is my sound okay, or do you think I should upgrade my microphone? I mean, it's pretty clear, but I'm just wondering if the sound isn't as good as it could be or should be. Oh, Mike seems fine. No, I'm not monetized. Nope, never been monetized. I don't. Nah, I never got the 4,000 watch hours, and I think that's now dropped down to 3,000 watch hours, if I read it correctly, or like 3 million clips are basically equal, about the same. If you get 3,000 watch hours, you're probably getting the same when it comes to the small clips. So, okay, David says my sound is fine. Okay, then I won't go out and purchase a microphone then. I mean, I have one. It's just not, and obviously it's the one I'm using when I do my vids, but as you can see in my videos, that I bounce back and forth between having a backdrop, between not having a backdrop, between having a lot of special effects in my videos versus not. There was really, really no difference in viewership whether I spent ungodly amount of hours on the special effects on the video versus not. So I figure, why kill myself if it's not going to make the difference. Thanks, Ernie. Yeah, no, I'm probably one of many. I mean, yeah, that's 3,000 or 4,000 watch hours. it's pretty impressive to get that. Um, I think if I looked at my videos over the last 3 years, I probably have a couple of them that have gotten like maybe 6 or 7 thousand views, but that's just because they've been on there a while. But yeah. Anyways, that's I mean, obviously, if I did this just for monetization, I wouldn't be on here, But anyways, I do different tags like everybody else does, but uh, I am loving those special effects. Well, yeah. I mean, just to make that stupid Scully light up took me hours and hours to learn and how to figure out the program and snip it right. And as you see my earlier versus my later videos on special effects, you can see how I started to get pretty decent at it after a while. So, but yeah, I mean, but it didn't draw anybody more, So I tried to tailor the content, then I tried tailoring the tags, titles, and I mean everything that you guys all do, and that you've watched over time. It really is just a hit or miss, you know. Um, consistency. So I figured if I start doing more of these walks with time and more videos in between and tags and shorts, and I think I'm gonna also do like a small little uh, video during the week. Actually, I might do it tonight or tomorrow, and on the different professional magazines that we use in physical therapy, and we can use them in any healthcare, but specifically for my profession, to give people an idea of how the heck why do besides going to school. I mean, school only gives you just much information. I mean, you keep learning as you get out of school. So anyways, I think maybe I'll do some of that because I noticed like um, some of the finance gurus on podcasts and stuff like that, they use a lot of that stuff. Whether it's tagging from someone else's video or whether they're talking about something that's going on in the hi. So, anyways, hi Joe. Hi Joe's mom. Oh, my mom's on here. Hi mom. So so yeah. So basically I dropped those couple videos. We're not the one live where I'm on the river where I'm only there for I think I only put myself on there for like 3 or 4 minutes because I was afraid of dropping my phone in the river. I burnt my legs, so the top parts of my thighs got cooked. So I'm healing from those, a week and a half later. But anyways, uh, I always like to tell one of my horror stories when I'm out doing these walks. So, horror story number one. So I'm going to take you guys back to when I worked at a place back in Maryland in the late 1990s, way back when the moon landing. So anyways, I was working for a chiropractor. It was an office that had both chiropractic and physical therapy treatments in there. And interesting enough, that was new at the time. You'd never, I mean, and it faded out fairly quickly. You really have a divergence or separation between physical therapy and chiropractic. I mean, they're kind of like oil and water for the most part, just because, as I've talked in my other lives, some of the philosophies that physical therapy has are completely opposite, or as we would say in the business, juxtapose to what chiropractors do and vice versa. Since physical therapy has really gone gung-ho about spinal manipulations and kind of stepping in on some of the chiropractic turf, they've kind of gotten sore about that. But anyways, going back to when it's the late 90s and I'm working one of my first jobs. I think it was my second job. Yeah. Nope, my first job. I apologize. It was my first job when I first moved to Maryland. So I did it for about a year. Mom always says at least work a job for a year. Doesn't look good on the resume if you don't. And so I worked there for a year. And the horror story I have for you is here I am a lot of times we were treating the same. So the chiropractor would do the reevaluation and treatment, and then they'd come to physical therapy after. That's kind of how it went, because really the chiropractor only did a few things. They did some joint manipulation. They might do some heat, electrical stim, and then they sent them to us to physical therapy. So, and we focused mainly on um, other modalities like maybe some ultrasound and diathermy, some other things that we did back then. And so, patient comes in, and it's happened more than once, to where they were asking us, hey, the chiropractor said I have this problem and that problem. What do you all think? And so we were always having those debates between, oh my God, do we say that, yeah, I mean, what the chiropractor's doing really isn't making a difference, or it's really not making your symptoms better than they should, or sometimes they made them worse. I mean, if they went and did that manipulation and the joint did not give, all of a sudden everything flared up, and so they were coming to us. And we couldn't even do the physical therapy. We ended up doing, you know, getting the symptoms to calm down after the manipulation had gone wrong. So imagine doing that over and over again. I mean, it didn't happen all the time, but multiple times a week it probably did. And so that being the case, it's kind of like, yeah, I got to get out of here. I mean, reality is they're doing things they shouldn't be doing, making the patient worse. We're not even be able to do what we can do or we're supposed to do because they made the patient worse. So it was an absolute nightmare, sir. That's the horror story in that regard, where I had to get out. I was like, this is nuts. And then they're having lawyers there, and you're never supposed to have lawyers mixing in with healthcare. I mean, that's an absolute nightmare too. I'm like, I got to get out of here before someone breaks the law and I don't even know about it. Yeah, they're always yeah, that's right. Yeah. Well, that's true, Ernie. I mean, I could go on and on. I mean, I guess the biggest philosophy difference when it comes to a joint manipulation between what a physical therapist would do and a chiropractor is because we can do all the same thing. I mean, we can't do X-rays, we can't do imaging, so that's one thing that physical therapy can't do. But back to the manipulation piece. If you're having radicular pain, numbness, and burning in the leg or in the arm, a joint manipulation, you're not supposed to do that. It's what we call a contraindication, because at that point you're not certain if the disc is pushed out and that nerve is really what we call hot or inflamed so bad that if you do the manipulation, you could tear the disc, you could rupture the disc, you could fragment the disc. I mean, when something's that fragile, it's very easy to tear a piece off, and now you're dealing with a floating body within the joint space. So, but chiropractors, they'll do that all the time. They'll talk about how symptoms are reduced through joint manipulations, and how what we call the autonomic system calms your pain level down because it gives off histamines and histamine block, all this other nonsense. And there's a kernel of truth to that. Very small kernel of truth. That's true. A joint manipulation does give off pain relieving properties with histamine blockers and stuff like that. Very short lived. And then after that, the rebounding effect occurs where all of a sudden the muscles tighten up. And if you're dealing with any type of nerve problem, that's also flared up at the same time. So really, the only reason why you should have a joint manipulation. Now, I mean by this is there's 5 grades to a manipulation. Grade 5 is what everybody just thinks of as a joint manipulation. But there is a 1. And a joint manipulation grade 1 is like just me doing this. They would define that, what I'm doing right now with my fingers, as a joint manipulation. And you know what the crazy thing is? Is they would bill for that. That's right. They could bill for this. Now they would push it, wherever you have a pain at, but that's a grade 1 or grade 2. I push harder or my fingertips turning white, that's a grade 2. So they would build the same whether they did a grade 5 where you hear the pop and cracking or this. Now, what they do is they'll use a little tool. It's got a spring on the end of it with a little rubber tip, and it's got two kind of like half C metal pieces that your fingers wrap around, and you just push on it, and it kind of makes that snapping noise, and then that plunger kind of pushes into the skin. Now, excuse me, they'll call that, "Hey, how you doing there, Be Difference? Hi, everyone." So yeah, so that they'll do that, and they'll call that a joint manipulation. Yeah, it's a grade 1. Are you are you doing anything? Are you facilitating improvement in whatever you're talking about? I mean, if you want to talk about the vascular system, yeah, I mean, me just pushing on my fingers right there, I mean, technically, scientifically, yes, I am causing something to occur. Yeah, I'm causing blood flow to come to my fingertip. If I squeeze hard enough, it's going out. And when I come back in, it comes back. It's why my finger's red. It's rebounding. We do it in the fingers. They call it capillary refill, just to see if you have any vascular issue or something like that. But needless to say, that's what they call it. And you know, if we had a patient, give you an idea. If we had a patient, uh, if they were in a car wreck and their neck is really stiff and guard because they have all this neck pain from a whiplash injury, which means is you have micro tears in the tissue, and that's the muscles, the soft tissue, which is what we call the fascia, that kind of lines all the muscles, that gets torn and it can bleed and get inflamed. If we're dealing with a scenario like that and we're trying to improve blood flow, this isn't going to work. I mean, you could say it's going to work, but it's not. You're better off a heating pad, a water bottle, anything will give you a lot more bang for your buck than doing this and calling it a grade 1 or 2 manipulation and charging someone $40 for that or $50 or whatever it is now for what we call CPT codes. Those are codes that, depending on what type of treatment you're doing, has a dollar value to it. Anyways, so that's, I mean, so when you start seeing that absolute nonsense, and it's not criminal, I mean, but it's not ethical. It's just, I'm not, if you have any ethics at all, you're not doing anything like that to people and charging them. If you want to educate on them, like I'm doing right here, and say, hey, it's under very, when would you use that? That would be a good, I've seen them spring thing before. Oh, you have? Okay. So you know what I'm talking about. I called it the plunger, but they would use that. That's their soft tissue manipulation. And they'll charge you for that just like you would a joint manipulation, a grade 5, which, grade 1 is just a little bit. Grade 2 is pushing in. Grade 3 is where you're going halfway through the joint motion. Grade 4 is you're at the end of the joint motion. And then grade 5 is you're at the end of the joint motion and do a quick thrust. That kind of gives you just a general idea of what the heck is 1 through 5 even mean. So that gives you a decent idea right there. But, if you're going to do a grade 5 manipulation, you're doing it not because the muscles are guarding. Because if you can get the muscles relaxed and you're still restricted in your whatever joint you're talking about, your fingers, your shoulders, your whatever, we would call that hypomobility, okay, the lack of mobility. And only then would you want to do manipulation, because maybe you're dealing with, maybe the joint is stuck for, this could be from a nervous system issue. It could be scar tissue from an old injury or something like that. Now, that's possible. It's very far and few between. I mean, you're doing manipulations on every patient that walks through the door, and you're charging them 40, 50, 60 bucks a pop, literally, physically, and, and figuratively, then yeah, I mean, that's absurd. I mean, something's not right there. I mean, either A, Captain Obvious would say is you're overusing a technique, or you're a poor evaluator because you're using the same treatment on everybody. like a cookie cut stamp. You know, what the hell are you doing? So anyways, that's why there's such, I wouldn't say animosity. You could, but there's a lot of issues between the chiropractic community and therapy, and that's the reason why chiropractic has really diverged out in the last 10 or 15 years. You have like three different, at least the last time I looked into it, three main kind of categories of chiropractor. And, the one category would be the old style chiropractor that you've seen back in the day, like the 80s and 90s, where you go in and they just kind of jump on you and then they send you on your way. And then there's kind of like the newer age that had like the homeopathic chiropractor that has the herbs and the oils and the incense, and they'll have some what they call therapeutic, um what's the word, what's the phrase the states use a lot of times. Oh shoot. Oh, I know what it's called. Modality privileges. That's what it's called. Modality privileges, which basically means is depending on the state that they're working in, they do have or can get licensure to do ultrasound and ultraviolet treatment and magnetic therapy and all these other you know Reiki and dry needle, and they can get all these different techniques out there that are really physical therapy only. But if you are a certain state and you're licensed to do it, you have those treatments, or those options to treat a patient with those modalities. So, needless to say, that's been a big issue with physical therapy because of that. Tis for tack, I guess. We get the manipulation, and they get some more modalities. Who knows? Maybe at some point, 100 years from now, we'll all be blended together, and there won't be a difference between physical therapy and chiropractic. But you know, needless to say, insurance companies wise, a lot of insurance companies do not even recognize chiropractic as a profession. So you know, that's the reason why you see a lot of chiropractors that are just in private practice, where it's cash value, or they might have a credit card somehow linked to the web where they can do it that way. But Joe, you ain't healed till you have lit some sage and drank marshmallow tea. Marshmallow tea, huh? I've never heard of it. Hopefully it's marshmallows and not some other mushroom. Hey Joe and everyone. Hi, how you doing? Nice to see you. Long time no see, or see long time. So anyways, that's kind of like the kind of the skinny when it comes to really the real differences between chiropractic and physical therapy, and they continue to kind of merge and expand depending on what venue you're looking at. And what I mean by that venue is let's say we're in a spinal cord place, traumatic brain injury and spinal cord rehab. You ain't going to see a chiropractor in that environment at all. So, and guess what I guess, and physical therapy isn't in, they're in the car accidents and stuff like that. But um, I think where physical therapy wouldn't be a chiropractic, or what. I guess if you're looking at, there are some chiropractors out there. Now, a lot of this is done through DOs, which a DO, a doctor of osteopath, is a medical doctor. So they basically a medical doctor with chiropractic techniques, kind of like a chiropractor on steroids. And they go ahead and they'll do X-rays while they're doing the manipulations and stuff like that. They're into pain management. They might do spinal blocks and stuff like that. So that's the DO piece versus a chiropractor. That you would never see. You'd never see a physical therapy in. You might see us in the pain management piece, maybe like aquatic therapy, or you know teaching someone on how to use a TENS unit correctly. I've had videos on them that I've shown you in the past on those, and they've come down a lot in price over time. Uh, so, anyways, that's the chiropractic realm. Guys, have any questions about that? At least I can definitely give you more information on it if you wanted to. But that's the horror story I had regards to chiropractic, the company I worked with. The second horror story I have, God, that's loud, isn't it? I apologize. I can get by it pretty quick. Anyways, the second horror story. Hi. The second horror story is I was uh, I was inpatient. This is when I came back and worked in New York State. This was probably in the first. Here's the first year I was there, and they have a weird setup at that hospital. Their intensive care unit is like downstairs, or was downstairs, into a. Let me pass this before this guy. Sorry about that. Let me get by it quick so that you guys can hear me a little bit. Anyways, so I'm down in this intensive care unit, and I was there. I mean, we get evaluations down there all the time, but I was there this time because of a post-surgical that became a nightmare. So I talked about one of these in the past with a spinal disc replacement that we did back in the early 2000s. We were one of the hospitals in the country that was in a research project about that, and so I already talked about that horror story. But this horror story is where the patient went in for a scoliosis to fix that. And, to fix a scoliosis, you have rods, you have screws. And so people just think of scoliosis as kind of a curve. What they don't realize on the scoliosis is there's always a twist to it. So there's a curve and a twist to a scoliosis. And so you always have shortening on one side and lengthening on the other. And that also refers to any muscles, ligaments, tendons, soft tissue that is stretched over time, and that's stretched through as they grew. So their body and their nervous system completely adapted to that until arthritis wears down. And truly, they're dealing with an inflammatory process more based on pain than it is the alignment, because it's not till the alignment gets to a certain degree to where we have to worry about it, because obviously then it starts affecting your ribs, because your ribs can't open and close if you're all twisted up and turned. Next thing you know, you're dealing with hypoxia, breathing like you're supposed to. Anyway, so I'm down there, and back in the early 2000s, everybody was braced. I mean, jeepers, didn't matter what it was. The durable medical equipment made millions and millions of dollars on braces. Come to find out, 25 years later, half those braces were bull crap, as well as they didn't need to be needed. And what I mean by that is that hardware is screwed in there so tight that, and then the forces that the joint has when you move. I mean, you're talking, even though I'm moving right now and it seems fluid, or when you're moving, there are thousands of pounds of force, of torque on parts of your joint that your body is able to absorb and disperse throughout it. That's the reason, I'm talking to why your spine's that way, but, or why we're kind of, how we develop the way we do a lot of times is because it's the stresses of our environment, gravity, and walking and falling and all that other stuff. Tendons being grown and being stretched, that pulls on the bones, and they all do certain things as we grow. So anyways, when you quote unquote unravel or uncoil a scoliosis, because that's essentially what they're doing. They're going in there and drilling holes and putting screws in to try and get that spine as straight as they possibly can. I call that uncoiling, like you would a snake. Well, guess what? When you uncoil like that, you got lengthens and you got things that are being stretched extremely that have never been stretched before because they were in a shortened position your entire life as you were growing. And on the opposite side, everything is all laxed and stretched because you've now uncoiled that. So there's a lot of pain. And so I went in there, and of course, back then, they wouldn't even the physicians, the surgeons, their restrictions were like put brace on while in bed. And these braces were ridiculous. They call them a TLSO. So T stands for thoracic, lumbar sacral orthosis. And so they literally have a spot here, okay, kind of like two spots that hit you in the upper chest so that you don't twist at your spine, upper spine. And then you have a whole lower body carriage that crosses through your hips, and it's all back then it was a what we call a tortoise shell. It was a white plastic molded shell, and then you had a couple of Velcro straps. This is before they came out with the black newer age braces 15 years. I'm talking like 25 years ago, but even the braces that were 15 years ago, they don't even use them anymore because they found out that they don't do what they say they're supposed to do. When you look at if a person falls, is the hardware going to break? No. And anyway, so the horror story is I'm trying to get this person's brace on and in a hospital bed, right? A tiny little hospital bed. And they're all doped up. And even though they're all doped up, they're still screaming excruciating pain. You're trying to do what we call a log roll where, your shoulders, hips, and knees and back all move as one unit. And, there's three of us there. I'm evaluating them. It's just absolutely insane. You get the brace on, and now they have no movement, right? Because they're in a brace. You can't bend, so literally you stand them up like they're some sort of tin woman or tin man, because none of the joints can move. One, because they're fused and they're in pain, and you have muscle guarding going on, as well as the brace. The brace is kind of holding them there, so it's literally to try and get them to stand, and then getting them to stand is all fun because now they're doped up from the drugs, so that's screwing up their blood pressure. They haven't been out of bed. That's going to screw up their blood pressure, what we call orthostatic hypotension, where your blood pressure drops when you get up because of gravity and a bunch of other things. And then they have what we call vasovagal response. That happens. Needless to say, I get this person out of bed with two other people, and they literally drop on me like that. Freaking eyes roll the back of their head. The bed won't go down any lower. And this person was short to begin with, so it isn't like you could just swing up in the bed because the stupid brace is on and there's no pivot point. So let's just say the three of us lower this person to the ground, and in doing that, we had to classify it as a fall. Yeah, it only gets better. And then we end up. She ends up obviously coming back once we get her down on the floor and we lay her back out. Her blood pressure comes back, and she comes back, and it was an absolute nightmare. And so it was just. It's just saying you just don't know what's going to happen when you go into a post-surgical room, whether it's a simple knee replacement or hip or shoulder, some sort of spinal surgery like mine was, that I had to evaluate and treat. Between meds, blood pressure, pain, anxiety, person's anxiety, they don't know who the hell I am. I'm getting them out of bed. They just had major surgery. They're out of your mind. What they don't realize is your risk of pneumonia, blood clots, digestive issues just shoot through the roof if you do not get them out of bed as soon as possible, and which can kill you. Forget the surgery. Surgery could be a success, but the patient died because they blew a blood clot. That doesn't help things. So, no matter, you can go ahead and give them antiplatelets and anticoagulants, which we call blood thinners. Uh, you can give them all that, and the reality is, you know, it makes a big difference. Don't get me wrong. If they don't have those things, they'll blow a blood clot really fast. But the tall tale is you got to get them out of bed, get gravity, get that blood moving throughout the entire body, from the extremities of the arms and the legs, where all that blood sits and pools. So it's very, very important that you you get someone up and moving as soon as possible after surgery, no matter what it is. So, but if you all are ever wondering, oh, it's dangerous getting someone out of bed. It's more dangerous keeping them in bed. Forget, forget, bed sores, UTI infections, upper respiratory infections, all the all the other things that can happen because you don't get a person out of bed within 24 to 48 hours post surgery. There's so many. I mean, there's so much research that says if you don't get them out of bed, you're likely going to have a real problem. So it's it's interesting that uh, I guess it's just a lack of education. And you tell 10 people, hopefully they tell 10 people, and it just becomes exponential after a while. Everybody knows it. You got to get a person out of bed, not because you hate them, but because you want to give them pain. PT is pain and torture. It's not that at all. You just know all the severe side effects, and you don't want to scare someone half to death too, either. I always throw one scary thing at them, and usually that kind of jogs them enough. So like, okay, I'll get out of bed, and then, you give them enough, you throw enough education at them that they like, okay, yeah, this guy or girl knows what they're doing, and I'm a fairly strong guy. The tough part with physical therapy, stereotypes is most of the profession are women. A lot of them are like 5'8". They go like a buck 50, and if someone weighs 200 and some pounds, and a lot of times you're trying to get them out of bed, and if they give, they're probably just going to fall solid because that person's truly not strong enough to lower them to the ground, not keeping them from falling. Because the reality is, if someone's going to fall, they're going to fall. Once those knees bend and you're not able to block them to keep them blocked in a straight position, you're going down. I mean, I've had 100-pound people drop on me, and he felt like 200 pounds. It's quite amazing. Dead weight. There's a reason why it's called dead weight. 100 pounds feels like 200 pounds when it drops on you like that, because it's instant. I mean, it's you gotta be ready at any moment in time. But anyways, so that's horror story number 2. That was a long horror story, wasn't it, folks? All right, horror story number 3. This will be my final one, at least final horror story. Imagine that, I think back on that and I think, oh my God. But so anytime you evaluate someone in their home, I'm talking about home care now. This is the first time I did home care, and this is probably 7-8 years ago now, pretty close to it, somewhere around there. 7 years ago when I did home care the first time. You're going into people's homes, you have no idea. I mean, you're calling them, you say, hi, I'm so-and-so, I'm coming out to see you. Oh, yeah, they sound great over the phone. Then you show up at their house, and it's like, it's like the Bates Motel. I mean, it's like, really? So you knock on the door, you go in, you pray to God that there ain't bed bugs and everything else around, and we do have suits for those, and you can come back out and hopefully put it on. But the horror story is I went to this person's home, sweet, sweet lady, and she broke her leg. She was an older lady, and her husband was there. Now, her husband had dementia, and it wasn't even mild dementia. This guy knew his name, and that was it. He didn't know where he was. He didn't know what time of the day it was. He was not safe on his own at all. And so I'm in this house. She's the only one there with him. He's completely mobile. There ain't nothing wrong with him physically. He's got nothing upstairs besides he knows his name. Let me get past this person again. And so, you guys gotta blow that lawn all day long. Anyways, so I'm in the house. it's like this step down. So I walk into this house that's like overgrown with woods, and literally I walk in the home, I look up, and the first thing I see is the kitchen, and the kitchen has a hole in the roof, and it's got a tree from outside over the top. You can literally see the tree, and I'm like, now this couple does have kids, and the kids come over, and the kids bring their grandkids over, and they leave their grandkids there while they go out and do stuff. She's in a wheelchair because she broke her leg. She can't put no weight on it, and her husband's got severe dementia, and they're leaving their kids there so they can go do stuff. I wish I was making this up. I couldn't make this up. It's too good to make up. So I'm there. She's been told not to put weight through her leg. She's got this step down house to where she has like this a sunken living room, I think they used to call them. I guess they were big in the late 90s or whatever. And so she's literally stuck in this one spot because she's in a wheelchair. How's she going to get to the next step up on the other side? So I literally have to devise a way through a ramp that's long enough because she's not very strong for her to get herself up to the next level. It's absolutely insane. So I successfully did it. Kudos to me. And, it's kind of like, I try to reach the kids. Kids could never be reached. It was really a sad situation. And I think we saw her she went back to the surgeon, and then the surgeon discontinued home care services. And I had told them the whole story of the doctor and stuff like that, or the doctor's physician assistant. And, just to kind of give them a heads up, because a lot of times they go to these appointments and everything is like, surprise. Oh, really? Oh, I didn't know, because they're going there and they're putting on the best face that they possibly can for the surgeon, and not realizing in their home is literally falling in on their heads. Now, the reason why they didn't fix this house is because they were trying to sell it. Now, not only were they trying to sell it, they were trying to sell it to a corporation because their land was in a hotspot area to be bought up and put houses on. Now, I drive by there every once in a blue moon. It never got sold. So, and I don't even know if they're both dead and gone now. Needless to say, the house, the front of the house is all overgrown. It's worse than it was before. There is a car there, so I'm certain she's probably still there. Hard to tell. I'm not there enough, not driving by enough to see if the car comes and goes. But yeah, that's a sad horror story that you go to these people's homes and you just don't realize it. I done passed out 12 X's listening. Well, don't pass out, hopefully not. So yeah. So those are the 3 horror stories that I have for you all. So hopefully you'll put a thumbs up and a like in my videos. The live streams probably, that'd be great if you would, but definitely my edited videos, get them out there. Really just to help people. It's amazing how some videos will do fairly well, at least from my standpoint, and other ones just bomb. So anyways, as I finish up this nice walk, I think this is number 10. If I remember 10, I think so. I think this is number 10 on my walk list. And the funny thing is, I remember you all from when I started, so you guys have been doing this probably longer than I have. So, as I always say, look up and keep smiling. See you next time, folks.